A very good morning, ladies and gentlemen. Thank you so much for joining us on this Saturday morning. This is Murali with the National Cancer Society of Malaysia, and we're back with this month's extension of the SK Dharmalingam series on cancer awareness and control. So we're very privileged today to have with us a very distinguished physician who has really put aside, Saturday is always a very busy day, and he's very kindly put aside his clinic this morning to be able to speak to us. So we have with us Dr. Arnil Sirimanne. He's a clinical oncologist at Prince Court Medical Center. Dr. Arnil, good morning. Thank you so much for joining us.
Hi, good morning. Thank you for inviting me to give this talk. It's a very broad talk, but let's see what we can do.
Will do. Ladies and gentlemen, as you know, the SK Dharmalingam series is geared towards kind of providing you updates and information pertaining to various aspects of cancer management. And this month is National Cancer Survivors Month. And it's always kind of appropriate to look at survival and how survivors can better optimize their lived experience, looking at how they manage to prevent recurrence of their cancer, prevent the occurrence of new cancers, and lead very good quality lives well after they've completed the acute phase of their disease. So what we need to do is, from the physician's perspective, when we approach survivorship, as physicians, I think it's time to also look at how do we better manage those survivors that come to us. So those survivors, whether they are under your acute care or whether you're under your follow-up, especially in primary care. So what are the things to watch out for? What are the things to look out for? So Dr. Arnil this morning has kindly kind of put together this entire plethora of information pertaining to how to look at survivorship and how to kind of better manage your patients who are survivors. So without further ado, please allow me to turn the stage or the camera over to Dr. Arnil, who will walk us through this. Doctor, it's all yours.
All right. So are you guys seeing my slides?
Yes, we are, Doc. Clear.
All right. Okay. Good morning, everyone. Again, thank you to the National Cancer Society for inviting me to give this talk. I felt that this topic was quite, not say difficult, but to summarize cancer treatment and in terms of aftercare, and many of these patients will probably come to your private GP clinics and to be seen for other issues at hand. But it'll be good to know what are the treatments that most of these patients have had, and just to get a brief understanding on how we deal with cancer patients as an oncologist myself and how I deal with them. So the topic is from fighting to thriving, managing post-treatment cancer survivors in the primary care setting. I'm Dr. Arnil. I'm based in Prince Court Medical Center. So let's move on to the next slide. So I have no disclaimers, none to offer. So, okay, let's go through. These are the questions that a lot of doctors would ask, and of course, patients would ask them, I will go through, generally, most of these questions should be answered in my presentation. It will not be in any order, but let's look at some of the questions like, when is a person considered to have completed primary oncological treatment? What is remission in cancer? What are the signs and symptoms of cancer recurrence? How often should cancer patients be followed up by their oncologists? What do I do as a primary care doctor, GPs with cancer patients that have completed their treatment? Number 6 would be, what are the common medical concerns in post-cancer treatment? And number 7 would be, when do I refer back my patients to the oncology services? Let's move on. Okay, let's move on to definitions of treatment. I think everyone should be clear what are definitions of treatment. In terms of cancer care, you need to be aware what neoadjuvant treatment means. These are treatment given as a first step to shrink the tumor before major treatment will be given subsequently. So what some patients will undergo is they might undergo chemotherapy first, radiation, some hormonal treatment before undergoing surgery, which is the definitive treatment. So you need to understand what neoadjuvant treatment means. Adjuvant treatment is basically giving further treatment after the primary treatment has been given prior to that. Like, for example, as I mentioned earlier, patients would have had chemo followed by surgery, and then they might or might not have further treatment that would entail more chemo, more radiotherapy, and there's other things like hormonal or targeted therapy. Palliative care you should be aware, you should know this, that this is actually treatment to relieve disease in a metastatic setting. These are meant to, to keep patients more comfortable. It does not cure the cancer, but basically it keeps them comfortable. We try to reduce their pain, and there are many methods that are available here where we can use surgery, we can use radiation, chemotherapy. Of course, palliative care comes into play here. And the idea is to, to reduce discomfort, to reduce pain, to reduce suffering. So all in all, in this topic, I'm not going to deal with palliative care. I'm going to deal with, radical treatment, treatment after, in terms of curing the patients. So that's where neoadjuvant treatment and adjuvant treatment comes into play. So we all know, based on this diagram, what chemotherapy is, what radiotherapy is. So I think this pictogram should be more than enough to let you know what it is. Let's go through definitions of cancer remission. So, and as well as survivors. So remission is a decrease or disappearance of signs and symptoms of cancer. So the patients would have had treatment, and when we follow them up in the oncology center and we do scans and all that, and if we do find that the tumor has gone away, or basically, has regressed but not gone away, this is considered partial remission. This remission would probably be looking at, in the palliative setting, where the tumor has regressed slightly or shrunken but not gone away. This is considered partial remission. Complete remission is where all the cancer has gone away, when we do any scans or we monitor them with tumor markers and whatnot. Survivors, cancer survivors, these are one that remain alive and continue to function during treatment and after overcoming serious hardship in life-threatening disease. In cancer, a person is considered to be survivors from the first time of the diagnosis until the end of life. Moving on. Now, I've managed to get this pictogram from the internet. I couldn't find something similar to represent Malaysia, but this would give us a brief gist on the 5-year survival. Now, if you pay attention to the red dot, where they're talking about, between the years of 1970s to 1977, the black dots represent 2007 onwards. Now, generally, we can see that all cancers, the survival rates are increasing. And there are certain cancers we are doing much better than over the years. We've gotten new treatments, new ways to manage these cases in an attempt to cure them. So the reason for improved survival would be early detection of cancer, or improved treatments in general. So over the years, since I've started, in my training, you can see that there are more and more newer techniques to manage cancer patients, and you would see them, they are surviving more, and we are curing them more from their cancer. So this is something that we all need to be aware of. So what is important about cancer follow-up? There are two things here that, as an oncologist or as a doctor per se, that we need to know. Now, we're always worried about recurrence. So when we follow up our patients, we need to look for early recurrence. Number two, as an oncologist, maybe a lot of us don't really pay attention to, but we also need to look at long-term complications and side effects from our treatment. So with advancing treatments, patients survive longer. When they survive longer, of course, there's a risk of recurrence, but also there's something that if patients tend to survive more than 5 years, 10 years, there's still risk of complications from our oncological treatment. And this is something that we need to know and something that we need to define, which is which, So let's segue to the next part. So long-term complications and side effects can be divided to, from surgery. We all know that surgery, probably not so long-term, probably the acute, in an acute setting where there's bleeding, pain. But in terms of systemic treatment, where there's chemotherapy, endocrine, targeted therapy, monoclonal antibody, immunotherapies, all these things can have long-term side effects. And the patients will inadvertently mention to you that I'm still having this, I'm still having that, and these things may not go away. Radiation also plays a role where, yes, we are treating the tumor, but there will be side effects, potential side effects later down the years. If a patient develops early severe side effects, say during treatment, that doesn't equate to late side effects. If someone has less early side effects, which is probably during treatment, the late side effects may be severe later down the line. So someone would define that maybe patients who, after completion of treatment, if they have side effects, it may be 3 months and above after completion of the treatment. Moving on. So I've just broken down the potential late side effects in here. I'm not going to talk much about the early side effects. The early side effects generally are mostly managed by the oncologist because we still see them quite during our follow-up. But I think what I want to highlight is the potential late effects of treatment that you could come across in your clinic. Chemotherapy can cause fatigue, pain. There's a risk of cardiotoxicity, peripheral neuropathy, ototoxicity, and also, of course, there's a risk of secondary malignancies. Somewhat similar, you would find this in the immunotherapy scheme, but it might be a bit more sinister where there's still fatigue, there's still Addisonian crisis, there's thyroiditis, skin reactions, fibrosis, and these are all more peculiar towards targeted therapy, immunotherapy as such. Radiotherapy, well, side effects actually depend on where the site of radiation that was given. I'm just talking briefly, say, for example, breast. So when we give breast radiation or chest wall radiation, the effects are more of local, where there's skin pigmentation, breast fibrosis. There may be cardiomyopathy, especially when the radiation is in the left side of the breast or the chest, left side of the chest wall, where the most of the heart is at. Pelvic radiation, you might find things like, skin pigmentation, where you can see the skin as darkening, chronic proctitis, cystitis, and these things can actually go on for years. And whether it resolves or not, it really depends on per patient. And this is something that we always tell our patients, that you will still may have all these side effects. So it depends on the site of radiation. If you treat the brain, there'll be local effects to the brain and such. So these are just basic, diagrams of potential toxicity from radiation per se, where you can see, this is a head and neck tumor. The first two diagrams are just head and neck tumors where there's skin reaction, and this is probably in the acute phase. And if they resolve, if they improve, it might, the skin may be darker compared to what is normal. And among the breasts also, you can actually see that. So sometimes when you see a patient during a follow-up, if they say, I've got a new lump, then you look at the skin and you might say, oh, why is the skin abnormal? Is this reaction? Is this reaction, or is this radiotherapy side effects? So there are two different things that you need to consider. So what are the general follow-ups that, as an oncologist, what do I do? What do we do when we see our patients? And you could apply this in your practice. How often do the patients see the oncologist? And this basically is tailored to each, histology, where we are worried about earlier risk of recurrence. Okay, for example, we are looking at a TNM staging. T1 small tumor, lymph nodes negative, T1 N0 M0 versus a T3 N3 M0 breast cancer. Obviously, a T3 N3 would be more higher risk of metastasis or recurrence. So we tend to see these patients a bit more closely compared to a T1 N0. Similar with a colorectal cancer, where there's a T4B N3 disease, M0, where there's colorectal cancer. These colorectal cancers will probably be seen a bit more frequently compared to a early stage tumor, but generally they would have almost a similar sort of treatment at the end of the day. Of course, stick to the basics in terms of your patients. Proper history taking, what are the symptoms, where, lumps, bumps, new side effects, any bleeding here, per-rectal bleeding, cystitis, and such. Physical examination, examine your patients properly. You might be running some blood investigations like blood, full blood count, renal function. These are the basics to look for any abnormality. Liver mets you may see, liver dysfunction if there's liver metastasis. Basic radiology, like chest X-rays can show you a lot, especially if you're worried about lung mets, that sort of thing. You might leave the CT scans and all that in the general hospital per se. So recurrence or relapse, well, it's generally about the same. The recurrence of disease, you need to think about whether it's local recurrence or distant recurrence. If it's local recurrence, obviously, as an oncologist, we would probably be looking at doing a proper scan to know whether it's distant mets or not. But in terms of local recurrence, for example, if we talk about breast cancer, if there's local recurrence to the chest wall or the same breast, then a lot of times we can resect that tumor. So, and the patient may need further treatment subsequently. Distant metastasis is, they can actually present with shortness of breath, which represent lung mets, pain and liver dysfunction, liver mets, headache, nausea, vomiting for brain mets, and ascites would represent, peritoneal disease. And of course, there's other things of bone metastasis where, they can present with bone pain and fractures. So the recurrence is something, so you need to be aware when your patients come in, of course, look for local recurrences as well as distant metastasis. So I'm going to talk, as I mentioned earlier in my slides, I'm going to talk about radical treatment or patients that we are aiming for cure. I'm not talking about palliative setting. So I'm just going to talk about these few cases, breast, colorectal, cervical, nasopharyngeal, head and neck, which overlaps with head and neck tumors, prostate cancers, and these are generally most of the bulk of the diseases that we see in Malaysia, and we always try to look for, these cases, and we are trying to aim for cure. I'm not discussing about hematological and pediatric cancers. They're out of my league. I'm not, and as I mentioned, not discussing about palliative care. This is briefly what I'm going through per site. I'm going through the general management, followed by their follow-up, and their follow-up. So breast cancer, the early and operable cases. To confirm breast cancer, we always have a biopsy, and if there are no distant metastasis, if the patients can undergo either surgery first, but sometimes the surgeon may ask us to shrink the tumor with neoadjuvant chemotherapy before going for surgery. So I know these slides look a bit confusing, but biopsy, neoadjuvant chemo, followed by surgery, and the patient may go on to have radiation and more endocrine treatment, and then they will be followed up. Or patients will just have the biopsy followed by surgery, and they will have their chemotherapy, radio, and endocrine treatment. So this is just a brief outline on how we manage. It's actually more complex than what it seems. And then this is a diagram of someone undergoing radiotherapy to the breast. So follow-up for breast cancer, what is advocated or what is suggested is regular follow-up, which is adapted by the risk of recurrence. As I mentioned earlier, if higher nodal positive disease, you might want to follow them earlier or more frequent. But this is suggested that every 3 to 4 months in the first 2 years, we need to look at them, physical examination and history taking, and every 6 to 8 months from the subsequent year 3 to year 5, and annually thereafter. We would recommend annual mammogram, a regular bone density evaluation, because a lot of these women are on the elderly age, and with treatment also there's a risk of osteoporosis as such. Advocate healthy lifestyle, diet modification, exercise. This is all what we should be advocating. So between relapse and late complications, as I mentioned, relapse, watch out for sites of possible relapse. This is where you will have local recurrences to the chest wall, to the breast, look for new lumps. Then, of course, ask them about, bone pain, shortness of breath, brain metastasis is where they can have headaches, examine the abdomen, look for, abdominal distension, where these things can happen later down the line where they can have metastasis. Late complications, surgery, there might be risk of lymphedema. Chemotherapy, there's late onset of cardiotoxicity, fatigue, pain. Radiotherapy side effects, as I mentioned, there's side effects. This is radiotherapy to the left breast. So the radiation is in the colored area. That's where we are giving the radiation. So we can see where, the whole breast can have the, the late side effects where, and of course, the lymph nodes, the lymphatic drainage, there's, increased risk of lymphedema, breast fibrosis, there's maybe rib fractures down the line. The heart is in the field of radiation. Some would get cardiotoxicity from radiotherapy. And of course, when you talk about endocrine treatment, where, we give them 5 years of adjuvant endocrine treatment, which is an oral medication. This is to further reduce the risk of cancer coming back. So we do need to highlight the fact that, things like tamoxifen, which is for premenopausal women, which is more suitable for premenopausal and postmenopausal women. But there is a risk of, of endometrial cancer from this, from tamoxifen itself. So I always advocate that the patients need to have regular follow-up with their gynae, need to let the gynae know that these patients are on tamoxifen and watch out for endometrial cancer. The risk is low, about 1%, but it is there. So we need to highlight the fact that tamoxifen can cause endometrial cancer. And there's, of course, a risk of DVT. We tell them that, watch out for leg swelling. And of course, the other part of pulmonary embolism, shortness of breath, which needs to be ruled out. Is it lung mets or is it shortness of breath from DVT? That sort of, pulmonary embolism. Aromatase inhibitor is another hormonal treatment that patients undergo for 5 years, and it's meant for mostly postmenopausal women. And this can have osteoporosis, long-term complications of osteoporosis. And we need to monitor them with a baseline bone density scan, and then regular, and some of them may be on Zometa or, to reduce the risk of fractures. And of course, you try to give vitamin D and calcium supplements to reduce that. So that's generally about breast cancer. Colon cancer, colon ascending, transverse descending. Basically, it's biopsy to confirm with no mets. If there's no mets, they will undergo surgery. And we look at the risk factors of the histological reports. And most of them will, if early cancers, generally you may not undergo chemo, but if you do undergo chemotherapy from 8 to 12 cycles, and then subsequently you're under follow-up. Rectal cancer is a bit different, where, look here, rectal cancer, we deal with it differently. Of course, we can do surgery first, but a lot of times new data shows that giving upfront radiation plus chemotherapy for 25 sessions of radiotherapy, followed by surgery, and then some of them may undergo adjuvant chemotherapy, has a better outcomes in terms of a local control, to prevent the disease from coming back earlier. So that is rectal cancer. It is slightly different from colon cancer. Follow-up for colorectal cancers in general, surveillance is important for the first 2 to 5 years. History and physical examination. And if the CA levels are raised in preoperatively, you can use this to monitor the potential, if it recurs, the CA levels can rise, and this is where you need to do more investigations. Surveillance colonoscopy is important from at least yearly, and then 3 to 5 years thereafter. A CT scan, as an oncologist, we may, depending on the risk of recurrence, we may order them every year, or we may even consider a CT even earlier than that. Healthy lifestyle, as mentioned, diet, exercise, limiting alcohol, quitting smoking. These are all important things that we need to highlight to the patients. Relapse, again, we go through the same protocol, or relapse or late complications. In terms of local complication from colorectal cancer, look for abdominal mass, new colorectal mass, distant mets. You have that lung-brain ascites, as I mentioned earlier, almost similar to breast. Chemotherapy has the same so-called, potential side effects: fatigue, pain, neuropathy. And radiotherapy, you can have chronic cystitis, proctitis, skin pigmentation, secondary malignancy, which is also a possibility if these are potential problems that can arrive later. Let's talk about prostate cancer. Prostate cancer, not all prostate cancers, not all early prostate cancers need to have treatment. Some of them are just on active surveillance, where we follow them very closely, because there's this notion where we tend to overtreat prostate cancers. But let's look at the point where those are the higher risk of what distant metastasis, where we are looking at locally advanced prostate cancers, where they may be there's a few options of treatment where they can undergo robotic prostatectomy, or they can undergo radiotherapy. And prostatectomy, of course, is just one session, while radiotherapy, on the whole, when patients are not keen for surgery, then they can be referred for radiotherapy, and radiation sessions will take about 37 times the general consensus for prostate cancers. And subsequently, they'll be followed up. Now, how do we follow up them? Most of these patients who fail treatment for prostate cancer do so within, the data shows that it shows within 7 years of local treatment, whether it's surgery, whether it's radiotherapy. So not much is advocated in terms of imaging. There's no real evidence that ultrasound or bone scans or regular CT scans is a way to look for relapse. What we do is we monitor the PSA, and this is actually a very good indicator. If the PSA is rising, that's when we'll probably do something in terms of any form of the imaging, as I mentioned down here. Relapse or late complications of prostate treatment. Prostate cancer is a bit peculiar, where most of the time they metastasize to the bones, and they can present with fractures and cord compressions along the spinal cord. Very rarely we see them spreading to the lung, liver, or brain. It can be seen, but very rarely. A lot of times in my practice, we see them spreading to the bones, and they can present with fractures and cord compressions. Late complications, of course, surgery. It's one treatment, but there's a risk of incontinence, strictures, infertility, erectile dysfunction. And then radiotherapy, there's chronic proctitis, because radiation is basically affecting whatever organ that's around the prostate. So the bladder and the rectum tends to get a bulk of the radiation. So you'll find that they will have chronic proctitis, cystitis. They may have bleeding, like perectal bleeding. You may think that it is a rectal tumor, but yes, you need to rule out a rectal tumor. With a scope, you need to refer to a gastro to have a look whether it's actually a tumor or is it related to the radiation. And it can be irritating to a lot of patients, where they will still be having this problem, and it may be persistent for until the end of life, where it'll be bothering them. So, and there's also a risk of infertility, and there's also a risk of erectile dysfunction from radiotherapy. This is just a bone scan that we do, and we can see that the uptakes, the darker uptakes, are where, in terms of prostate cancer, and where they can spread, to the pelvic. A lot of them tend to spread to the spine and, ribs and all that. I mean, this is just more of a prostate cancer, but it can apply to any other tumor sites. So this is metastasis to the bones diagnosed by a bone scan. Nasopharyngeal cancers. This is one of those cancers where very common in Malaysia. It's common among the race group Chinese, Malays. Very rarely we see it in Indians. We see it a lot, very commonly among the natives in Sabah and Sarawak. Early nasopharyngeal cancers, or locally advanced nasopharyngeal is we're aiming for cure. So we are trying to cure these patients, and these patients are generally cured. They cannot be cured by surgery. It's generally where you confirm the by biopsy, and there's, of course, scan shows no distant mets. They will undergo some neoadjuvant chemotherapy to shrink the tumor, followed by radiation. And radiation takes about 35 times. And we can actually cure a lot of these patients. Of course, the earlier it's easier to cure compared to the later local advanced disease. Nasopharynx around this region, as you can see my mouse, and this is where we treat, and normally it's the nasopharynx region plus the head and neck, which will be undergoing the radiation, because a lot of times nasopharyngeal cancers tend to spread. It will either recur locally and it might spread to the neck. So this is just a diagram of radiation, how we give radiation for a nasopharyngeal cancer. The nasopharynx part will get a bulk of the radiation, where the red color represents higher dose, and we tend to give radiation towards the neck, which is a common site of lymph node common site of drainage and high risk of propensity for the tumor to spread to the lymph nodes. So in terms of nasopharyngeal cancer, we tend to treat the nasopharynx plus the whole neck. And if you can see, this diagram can show that over time, the tumor will regress. And this is what we want. So again, look for local relapse as well as late complications. So local relapse, we need to look for recurrent signs like epistaxis, blocked nose, in the nasal cavity, or new neck nodes. Examine the patient's neck, look for new lumps and bumps. Talk to the patient, is this something new? Is this neck node something new? It might be there previously, but if the patients are cured, it may occur, it may present as something new. And of course, look for distant metastasis, as I mentioned earlier, lung, liver, bone, look for symptoms and signs for that. And they can spread anywhere. Chemotherapy side effects, look for those complications, peripheral neuropathy, ototoxicity, nephrotoxicity. These are depending on what chemo we give. Radiotherapy side effects, skin. If you see your patient's nasopharynx, you will notice that their skin is darker than normal, where around the neck, around the mouth, around the skin on the cheeks. They will constantly complain of dry mouth, lost taste. The neck will be tightened because of muscle fibrosis. The cervical myelopathy, I'm talking about cord myelopathy, because there's some radiation that will probably go into the spinal cord. So of course, we do try to avoid long-term toxicity, but some patients may have, tingling or spinal involvement. There's a risk of hypothyroidism because the thyroid is in the region of radiation. So they may present later with hypothyroid symptoms. So it's always good to check the thyroid function test. There's, of course, risk of secondary malignancies. I'm not saying that it occurs immediately after 5 years, but if the patient survive, it can occur 10 to 15 years down the road. So how do you follow up for head and neck tumors or even nasopharyngeal cancers? Head and neck examination is important. Flexible scopes, generally not done by the oncologist, but normally done by the ENT physicians, every 2 to 3 months. After what I normally do is that after radiation, we must ensure that our patients are seen back by the primary ENT doctor who has, scoped them prior to this, to have a scope to look at the nasopharynx to see whether any recurrence is there. Of course, examine the neck to look for recurrence as such. Imaging, yes, it is important, especially more of the more locally advanced disease, where you would want to see how your tumor has responded to treatment. And of course, we want to look for recurrences. So sometimes you might do it every 3 months, every 6 months, depending on the risk of recurrence. Dental evaluation is important. Most of these patients would have had radiation to the head and neck region, and there'll be splash dose of radiation into the oral cavity. I should mention that a lot of times prior to radiation of head and neck, we would send our patients for dental clearance. This is to reduce the risk of osteoradionecrosis. And So we have to, if there's teeth need to be removed or dental cleaning need to be done, it needs to be done before radiation. There's of course yearly thyroid function tests. There's possibly that we need to check for hypothyroidism, as I mentioned. Tobacco, alcohol needs to stop consumption. So I think I missed out on radiation side effects. For late radiation side effects from head and neck would, as I mentioned earlier. So let's move on. Cervical cancers. Again, these are one of those cancers where we are aiming for cure. We have to detect early. Women need to be aware of regular pap smears and they need to see their doctors. So of course, there is a role for even early cervical cancers. There's of course a role for surgery. That will be the best option and to remove the tumor. Then we'll look at the histology. Some patients would require follow-up, just follow-up alone. Some patients will still need to undergo radiation. How about those cases where they are not possible to have surgery, especially very big cervical tumors where surgery is not possible? And that is where this is curative intent still, where they will undergo concurrent chemoradiation. And radiotherapy is actually about 25 times to 27 times. So it's a daily radiation. And of course, we need to follow them up subsequently. So just the basic gist on cervical cancer management. Relapse of vaginal cancers, of course, we need to look at if I have a patient under my care, I would insist on actually doing a vaginal examination every visit to look for local disease. That's the best way to know for local recurrence. You may not be able to feel any lymph nodes, but they may suddenly present with abdominal mass. They may present with obstructive uropathy because the cancer comes back. It may spread to the lymph nodes. It may block the renal system. They may present with obstructive uropathy, or they may even present with lung, brain, liver mets. Chemo complications, again, the usual, as I gone through earlier: fatigue, peripheral neuropathy, nephrotoxicity. Radiotherapy, again, is at the pelvic. The radiation is given at the pelvis. So skin pigmentation, diarrhea, chronic cystitis, hemorrhagic cystitis, these are things that can occur. Of course, menopause infertility is without saying. There's something that also we need to be aware. There's, of course, a risk of vaginal stenosis, something that we need to remind our patients or, explain to them that this can happen after the radiation. And this is important as we talk about sexual health and all that. So follow-up for cervical cancers, 3 to 6 monthly in the first 2 years. These are suggested follow-ups, 6 to 12 months in the next 3 to 5 years. Of course, history and examination, as I mentioned earlier: pain, new vaginal PV bleeding, vaginal examination, yearly cytological screening, which is probably done by the gynae oncologist. We'll do a pap smear, brushing to look for any evidence of recurrence. You might do a CT scan, to look for recurrence. And then follow up, you advocate better lifestyle, reduce weight, exercise. As I mentioned before about sexual health in terms of vaginal stenosis, a lot of women are still married, and these are things that you need to tackle. You cannot be shy about in terms of sexual health. So you need to talk about vaginal dilators, use lubricants. These are all important things that we need to deal, nothing to be shy about. All right. What else should you know? I've talked about the basic tumor sites and all that. I can't go, and there's a lot of other sites, obviously, in our head and our body, but I've just talked about the basic stuff. But what else should you know? I think these are things that you should be aware of in the back of your mind if you see a patient in your clinic. Oncological emergencies is what I'm talking about. You may not see it, but something to be aware, where the patient may just prop up to your clinic, even though they may be under oncology follow-up, but they do not know what to do. So an oncological emergency is an acute medical problem related to the cancer or its treatment. And this may result in severe morbidity and mortality. And if it's not treated quickly, it may lead to these issues. So these oncological emergencies, it may be secondary to a structural obstructive feature, it may be a metabolic feature, or it may be treatment-related complications. And also something you need to be aware of, even if the patients have not been diagnosed with any cancer, some of them can present to you in an emergency first manifestation setting. So what I'm trying to say here is that patients may present to it as an oncological emergency, and they've never been diagnosed with cancer, so it's a fresh new case. So something to keep also in the back of your mind. So some of the oncological emergencies that we can talk about are metabolic, structural obstruction, or treatment-related. Treatment-related, I would say that a lot of this, in this third box here, a lot of this would probably be managed in the oncology, in the oncology hospital, because these patients, we always tell them, if you have fever, neutropenic sepsis and whatnot, please come to hospital immediately. Don't do, if you have bad nausea, vomiting and all that related issues, then please come to hospital. Metabolic events, they may present with hypercalcemia, something that I'm going to talk about later, SIADH, spinal cord compression, very sinister, SVCO, raised intracranial pressure, airway obstruction, bleeding, pain. These are all can be considered as oncology emergencies. So in the ones in red, I'm just going to talk about briefly. Hypercalcemia can occur in 20 to 30% of patients with advanced solid tumors. How do they present? They can present with fatigue, anorexia, nausea, vomiting, abdominal distension, constipations. I think there's this thing called pains, stones, moans, groans, and all that. So they can present with this symptoms. And one of the more severe ones is somnolence, coma, and they can die. They can present with death. So we look at asymptomatic hypercalcemia, where the corrected calcium level is less than 3. A lot of times we manage them with hydration, encourage ambulation, and it can signify metastatic disease. And a lot of times we need to start chemotherapy for these patients as soon as possible. Symptomatic hypercalcemia, as I mentioned, with these symptoms above in the second point, a lot of times these are acute emergencies. If they present with hypercalcemia, we admit them, we give them IV hydration, and we can, provided that they are fit, they don't have other medical problems like CCF and all that, congestive cardiac. So we hydrate them with quite a bit of fluids, almost 6 pints of fluids. Furosemide may be useful to all these things to remove the calcium. And of course, above the level of 3, we have provided the renal function is normal, we offer them Zometa, which is to bring down the calcium as fast as possible. As I mentioned earlier, just watch out that, hypercalcemia, they can present with somnolence and coma, poor GCS. Think about brain mets also at the same time. Spinal cord compression. This is something very, very sinister. And this is something that you need to pay attention to, where patients can come into, they can just drop by your clinic, say, doctor, I can't walk for the past few days. And, they may have urinary incontinence and they are constipated. And if they cannot really walk, some of them will be bedbound and they already may present with bed sores. And this should, there should be an alarm raised. So examine them quickly, look for, signs of, lower limb weakness, check the power, anal tone if necessary. And in our setting, we always, do x-rays and we order for an urgent MRI, especially if we know these patients are our, cancer patients. We look for, where the insult is, and we start them on high-dose intravenous steroids to reduce swelling, but these are temporary measures. And if there's surgery that can be offered to remove the offending tumor, we probably can consider that, but a lot of times our patients go for urgent palliative radiotherapy. So that is spinal cord compression. SVCO, superior vena cava obstruction. This can present, a lot of times you can present with lung cancers, who present with a tumor in the superior vena cava region. It's mostly on the right side, as you can see. Can be diagnosed from a chest X-ray. They can come in with dilated neck veins, facial puffiness, dilated veins on the neck, upper limb swelling. These are signs, and sometimes they cannot lie down flat. And that's more of the severe kind of SVCO. Same concept of management, IV steroids, stenting, if it's possible to reduce the blockage. But if you look at this scan, maybe not so easy. We may offer urgent palliative radiotherapy. Not may offer, but we will offer some form of treatment where it's involved urgent palliative radiotherapy. And of course, chemotherapy, if indicated. Acute airway obstruction, where they can present with shortness of breath. If you look at the left bronchus and the right bronchus, you can compare that. it's completely blocked, collapse, consolidation is ongoing. These patients can present with acute shortness of breath. We may be able to stand this with by referring to the RESP fellows, or what we can do is radiation, to try and open up the this blocked bronchus, and hopefully the patients get better. And subsequently, if we know what the tumor is about, we can offer chemotherapy. Brain mets, also something that your patients can just come into your clinic. They may complain about headache, nausea, vomiting. They may have high BP. Most of the time they may not, but don't watch out for these issues. They can present as headache, nausea, vomiting. Confusion is probably the worst case scenario. Of course, you need to rule out hypercalcemia as an overlapping situation. So management, generally we do a scan as such to look for brain mets, urgent scan of the CT brain. Surgery, if possible, if we can remove the offending tumor, we will refer to the neurosurgeons. If they can't do it, then we will offer palliative radiotherapy urgently. And even if they have surgery, we'll still need to do radiotherapy subsequently. So these are one of the oncological emergencies. Bleeding from tumors, these are probably, if you look at these photos, these are probably more of the advanced patients who didn't have treatment, but just something to note that even those that had treatment, curative treatment, they may present down the road. They may be, they may not want to go and see the oncologist again. They may present with a bleeding tumor, and this is where they can bleed torrentially and they can die. So refer to the oncologist for urgent radiotherapy. This is bleeding of the tongue, which is also possible. I've had patients who've had, we didn't have time to give radiotherapy, but presented with just torrential bleeding of the tongue. And there's no real way to stop it, hypotensive, hypovolemia. And by the time we couldn't do anything, and they just bled and, they just died. So advice to patients, what are the post-cancer treatments that we can offer? That, as a GP, what do you do? Ensure the follow-ups are kept. Remind your patients, please come and see your, make sure that the oncologists have seen them and, reviewed them. At times after a while, sometimes maybe after 5 years, some oncologists would discharge them to the primary doctor, whether to their surgeon, or, we don't really need to see them because technically they are cancer survivors, they're free from cancers, but not all of them we do that, but so make sure that their follow-ups are kept. Healthy diets, balanced meal, exercise regularly are all important. Stop smoking, and of course alcohol consumption, limit your alcohol consumption and whatnot. So I guess this is the end of my slide. I thank you for listening, and I'm glad to take any questions from the audience, if there's any.
Thank you so much, Doc. As I think when you started off, you were saying this is quite a very comprehensive piece of work that you've put together. And thank you really for kind of compartmentalizing it by the different cancers and kind of providing us with a very quick and like very comprehensive understanding of what we need to look for within each cancer in terms of survivorship. Thank you so much for that. And this is really something that our colleagues should use as reference material. I think, Doc, there's a couple of questions if you're okay to take them.
Okay, no problem, no
Okay.
problem.
The first question is, Doc, I think one of our colleagues asks, generally, in addition to seeing the oncologist after they finished treatment, what is the timeline for them to be seeing the oncologist in a I suppose he says in a rapid manner. I think what it means is, how often do you see a patient when they finish treatment, and is there like a kind of a gradual slowing down of that?
Okay, yeah. Let's give an example of a breast cancer. Let's talk about that. More common. So surgery, chemo, radiotherapy. All right. After radiation is over, we tend to see them about 6 weeks after radiation. Okay. And we will probably follow up for a monthly first, and then maybe 2 monthly down the road. As an oncologist, even my medical officers in my previous hospital, we need to look out for, as I mentioned before, the complications of treatment. Because radiation to the breast or the chest wall, they may still be having those, the skin desquamation, breakdown of the skin. You just never know. It may happen down the road. So it will be tailored accordingly. But if I would probably manage it differently compared to other oncologists, but we would see them 6 weeks first, and then subsequently maybe a month or 2 months later. And it may go on for a year as such, 2 monthly follow-up. And then we'll see if the patients are comfortable, they're well, maybe 6 months, 4 monthly follow-up the next year, that sort of thing. As I mentioned earlier in the guidelines, there's not guidelines, but it's suggested follow-up in the previous slide in terms of breast cancer. You could follow that, yes. And I think it would be nice to follow those kind of follow-up schedules. But it would be tailored. Of course, logistics plays a role. Mm-hmm. There are not many oncology centers, especially in KL. Like Hospital Kuala Lumpur or even Institute Cancer Negara, they are covering other states.
Right.
So sometimes if they are able to come, then they should be followed up. So I hope that answers the question.
Right, and I think there's a follow-up from that kind of the question as well, as in Doc, from a lot of the kind of signs and symptoms that you pointed out could be issues related to like recurrence or late effects, but they are in different systems. So we're like discussing with the primary care colleague, what do you think in terms of, okay, a patient presents with one of these symptoms post-treatment, and generally with this very generalized symptoms, they're going to present to the GP. When they do that, should they kind of get in touch with you, or if for that matter, any oncologist who's managing this patient, kind of see whether have a sound check rather than sending this patient to another clinical specialist? Like what do you feel? Is there like a pathway that you have that it will be good to share with, like have a sound check or logic check with the oncologist who's previously seen the patient?
Okay, excellent question. Very good question. I would think that as an oncologist, being trained in the government setting, I think we are quite flexible in receiving our cases back again. So I'll give you some tips and tricks how to handle. So let's give an example. Like say a patient's under Hospital Kuala Lumpur follow-up, they normally have a book, okay, a small little book. Most of the time, the name of the oncologist is in that book, right? So if there's any issues that you're worried, okay, this patient of mine could have a recurrence. There are a few things. Of course, you can write a letter, and we allow patients to come into our clinic. They are allowed to come to our clinic. Of course, if it's an ad hoc, if they're not under follow-up, obviously they're going to take some time to be seen. But they should be able to be seen on the same day. If from previous experiences, there might be about 100 follow-ups per day, and you send an extra patient, to come in there, please write a proper letter, what you think this could be. Don't be shy. You may have it right, you may not have it right, doesn't matter. but it's something that we need to look at. So I would say send with a letter, to our clinics. Of course, the clinics are open on Monday to Friday only. But of course, if it's an emergency, please send them to Kecemasan, to the, But of course, there is oncology, MOs on call every day. There's an oncology specialist on call every day. So you can make a call through the operator to the specific centers, and you can have a chit chat. If you want to, you can speak to the oncologist on call. And if you know which oncologist, I mean, if you're talking about in the government setting, you can speak to the oncologist on call, and he or she could advise you what needs to be done. The MO on call also can advise you what needs to be done. And for me, I'm actually, as if I was an MO in training, I'm actually quite flexible. I need to see how severe the situation is. And sometimes we might see the patient the same day or even the next day, depending how bad it is. But again, watch out for the severe issues or manifestation of cancer, especially those patients. I know I've talked about radical treatment, but you'll just never know. They might just present down the road with emergency situations. So just give a chit chat, give a call. I think there's no harm.
Right. Thanks,
Did
Doc.
I answer? Did I miss out anything? Did I answer the question?
Oh, yeah. Good. That's really reassuring as well to, I think, many of our colleagues. Also, now it's a good thread. There's somebody asking another question on this as well, which is so if I see some kind of signs and symptoms with my patient, should I kind of start some preliminary investigations first? Would that be helpful, or should we just kind of pack the patient off? Because I noticed, and this is me really, I noticed that a lot of those conditions that you were saying, you can actually see some kind of lab differences or observations that you pick up from investigations. Would that be helpful?
I mean, it's not easy. It's not easy to answer this question. I guess experience and clinical acumen comes into play. I guess if you just need to know whether the patient is still under some form of follow-up in an oncology center. Okay, that's number one. Of course, if they are not under that follow-up, just find out which center they were in follow-up and probably send the patient back. But yes, you could. I mean, if say a patient presents with a lump on the breast or on the chest wall, possibly not much, then find out any other symptoms that this patient is having, examine the liver. Is the liver enlarged? Look for signs of, like weight loss, shortness of breath, sometimes these kind of things you can't wait too long. So I guess you would just have to pack them up and send them to the primary hospital. But I'm sure some clinics have their own X-ray machines and whatnot. Do the basics. Run the basic blood tests. If there is tumor marker related disease like colorectal cancers, you could run that. But have a baseline. X-ray will be more than adequate. Do your physical examination, look for neck nodes. If breast cancer, look for axillary nodes where this can spread. And this would be very helpful for the oncologist. Okay.
Got it. Lovely. Thanks, Doc. There's also, Doc, there's quite an interesting question on, there are many patients who complete treatment and now are no longer having active cancer, but they still continue to complain of persistent pain. And I think this person says, I keep on seeing them in my clinic. Any suggestions on how to manage this chronic pain, which seems to be not related to the cancer, but the patient still has it?
This is not easy. That is definitely not easy. Now, the question I would ask this participant is this patient still under follow-up?
I think the person mentions that no longer under follow-up.
Well, not so easy. Of course, when you talk about pain, you need to rule out, is this recurrence or not? Okay, so something that you need to ponder upon. Because if you have pain, where is the site of pain? Okay, but where is it? Of course, again, I'm going back to always breast cancer, but it's the simplest way. Like if you have radiation to the left side of the chest, the ribs, the skin, all may be, painful, that sort of thing, and it may be persistent. But of course, there are a lot of patients also. I'm not saying that everything is related to the psychological aspect, but having cancer on its own can also lead to psychological aspects, psychological pain, and I guess it's never easy to address pain per se. Of course, when you talk about palliative care pain, that's a whole different ball game, because that is definitely some form of pain there, and it's managed with opioids and other forms of analgesics, and it may be related to radiotherapy. But a question of someone who's completed treatment and having pain, persistent pain, I guess it's not going to be simple answer for me to give you in this day and point. But I guess what's important is to rule out, recurrence. Rule out recurrence. If you think that you want the patient to be seen in the private, back in the their oncologist, please send them off. Please call up the oncologist, call up the MO oncologist, say, this patient is still complaining about pain. I'm not so sure whether this is a recurrence or not, and let's see what you can do.
Okay, got it.
Okay.
Got it, Doc. There's also a question. Doctor, earlier you spoke about controlling the patient's other risk factors, alcohol, smoking, etc. Do you think this is a role that the primary care physician, the primary care practitioner should play? And why is this important for the patient who already has cancer?
Good question. I guess you have to realize that some patients can get other forms of cancer. You may have, say, colon cancer, but they can develop a so-called second primary. So yes, you would say that, the patients have got cancer. What's the point of, controlling my diet? What's the point of, leading a healthy lifestyle? But again, there is data to show that by, advocating, as a GP, you should be advocating exercise. All these things also for mental well-being. We all love our food, and, just eat in moderation, Also, there are other aspects of, they may have other medical problems like diabetes, high blood pressure, that all needs to be managed accordingly, So I think it all comes as a holistic approach to, in reducing the risk of recurrence, in a sense. So if certain smoking, yes, with head and neck tumors, higher risk, gastric cancers or smoking, all these things will cause a risk of further cancers coming about. So it's best to talk to these patients and tell them, you've got to cut it down, you've got to exercise, and we know that exercise can help you, reduce that. It's not going to 100% reduce it. No one is going to say that, but it will in some form or shape help out. No? And I think the mental aspect of it also, to tell the patients, get on with life. You've had your treatment. Easier said than done. Don't say get on with life, but something that we need to, slowly touch upon it, do what you like best, to lead hopefully a happy life in the future.
Right. Thanks so much, Doc, for that answer. I've got one more question, and this is coming from somebody who asks, if patients are no longer on active follow-up and they come to us for their annual medical checkup, as a post-cancer patient, is there anything in particular we should be examining for when we do their annual medical examinations?
You need to, again, go back to the question of finding out what tumor did you have prior to this. Okay. And then, of course, this is the problem with this talk, because I can't go in depth fully on every tumor site. Mm-hmm. So I guess as a private practitioner, I think there's a lot of things on the internet where you can read up about it, Medscape and all that. Again, physical examination. Okay. Again, let's go back to breast cancer. This is what I do. Yes, they do the yearly medical checkup, but in terms of what does that entail? That's going to entail history and examination, right? Question them. Any new lumps, bumps, any new systemic, how do I say, a loss of weight, loss of appetite, bone pain, these are things that you ask for. Then you examine them, examine the breast, examine the previous mastectomy site, any new lumps, okay? Examine the axilla, supraclavicular area where there can be lymph nodes metastasis, They may not have local recurrence, but they suddenly present with a cervical neck node, axillary leg, And of course, examine your lungs and all that. Then I guess depends on how much a medical checkup the patient is willing to go for. Some may, insist on doing a scan. I mean, it's difficult to say that a scan is the best thing to offer, but a basic chest X-ray would probably be the best. I mean, not so simple and straightforward, because a lot of times our cancer patients, we still follow them up as far as possible for life. There will be a few patients who have, either they would have defaulted, or either they decided not to go back to their oncologist and they decided just to follow up with the GPs. So oncology is actually a very big, ideal from head to toe.
Yep.
Head to toe, So I guess you have to buy a book somewhere, ABC on oncology. And I think you need to read up about, where, depending on which site, what are the common areas of metastasis, where are the common areas of recurrence. So these are the things that you need to question, the local effects as well as the distant potential metastasis, metastasis area. Not easy as a private practitioner, because you may not have all the necessary information on hand. You may not have the necessary history prior to that, and the patient may not divulge it. So yeah, it's all about getting the right information in. And if you're worried, then if you're concerned, then you got to refer out.
Right. And I think what's good, Doc, about your sharing today is, I think you've been very careful to tell us where the thresholds are, and I think this is really one of the big concerns, when do we keep the patient, when do we refer? And so thank you for providing us quite a bit of guidance.
It's not so easy. I mean, in the government setting, it's not so easy. I mean, the centers are overloaded. I mean, they see patients year in, year out, and of course there are complaints, and patients come in the morning and you'll see them like 12 in the afternoon, and there are fresh new cases at the same time propping up. There may be about 20 new cancer patients, So it's not so simple and straightforward. And I guess we also need to depend on the primary care settings to help us, guide us. But I also understand it's not easy for them, to know what is important, where at what point you need to, refer. And again, let's go back. There are new and newer treatments coming out. And even in a metastatic setting, I feel that we are treating patients in a chronic manner, like you're treating your diabetes, you're treating your hypertension. I think you need to look at that. Don't say give up on cancer, even if you're metastasis. You try to give them the best quality of life. And if we are able to give like 3-4 years of quality of life after diagnosis or progression of disease, that's pretty good. That's pretty good. So don't give up. But if you're concerned, you're not so sure, do talk to the necessary oncologist or necessary center for that matter. The only problem is that certain states don't have a proper oncology center. We have very few. Penang, Ipoh doesn't have any. KL, of course, the main centers are there, and then JB. So those in between will have to find out the best way to contact.
Right. Doc, as we, I think finished all our questions. And I think as we wrap up the session, Craig, I have maybe 1 or 2 things that I wanted to ask you to share with all our colleagues. The first is, Doc, as when your patients kind of go into completion of treatment, and as they go on to try to get back into work, get back into the community, basically survive better. any sharings what are the words that you leave them with that perhaps we could kind of take to tell our patients as well?
Okay, you're talking about getting back to normal life. Getting again, it's very subjective. These are not very easy. I would say most of the patients are quite motivated, but some of them not so motivated. After the cancer treatment has been done, some want to prolong their MCs and not get back to work. But these are things that you need to go slow with them. You need to talk to them, explain to them that you've had treatment, you're now in cancer free and in cancer remission for that matter, and we need to slowly talk to them. You need to get back to life. You need to get back. Easier said than done, because you need to word out. Even my words tend to change properly. I need to tailor it to the patient and what they are working as and all that. But in the gist of it, I just say, you need to get back to your normal life. You need to live out your life to the best of your abilities. Okay. It's kind of morbid to say, I have sometimes said it that we only live once. In this planet Earth, we're only going to live once. We've done whatever we can as human beings. We have done whatever we can. And now it's up to you to carry on with it. I mean, if you have kids, you have family, spend time with them, go traveling. Again, maintain your follow-ups with your doctor. It's not the end of it. You've asked me the most difficult of all questions, I would say.
Oh dear.
Yeah.
But it's a kind of good note to kind of end. And as maybe as we wrap up the entire session, Doc, any words of wisdom to us who are out there in the primary care, looking at patients? Anything to share with us pertaining to survivorship? Some last words.
So this is a wild west, is it? Out there. Yeah. I mean, I guess there's not really much to distinguish. I mean, as doctors, just be. I would say of course, this is all from training. Even as oncologists, we also get frustrated with certain patients in the sense of their demands of and they're worried about curing, getting well, and all that. But seeing a cancer patient is not that easy. You need to spend time with them, I would say. You need to spend time talking to them, dealing with their emotions. Not easy in our setting where we're dealing with so many patients. But I feel that if I were to give a piece of advice, I would say that not everything is just treatment related, chemo, immuno, radiotherapy, and all that. Pay attention to the psychological aspects of the patient. Take note of situations where there is depression. Pay attention to subtle signs of depression. And you need to tackle that. Not everything is going to be dealt with radiation. Not everything is going to be dealt with chemotherapy.
Right.
So if I were to give away as a primary care physician, take note of that aspect on their well-being. And if you think that there is some concerns, yes, I mean, you shouldn't shy about, psychiatric evaluation, but maybe you won't want to use the word psychiatric. Maybe you want to go for counseling, the word counseling. And most psychiatrists are quite acceptable to that notion. So, I mean, yes, you've got your cancer treatment, but also look at the psychological aspect of it. So maybe that's something that I think a lot of doctors should be well aware of, to be understanding in that notion.
Right.
Yeah.
Doc, with that, really, thank you very much for spending your Saturday morning with us.
No problem.
And ladies and gentlemen, thank you so much for joining us for this session. We had today with us Dr. Arnil Sirimanne, consultant clinical oncologist at Prince Court Medical Center, and he spoke to us about survivorship and how to look at aspects of managing that within the primary care settings. So thank you very much, ladies and gentlemen. Have a nice weekend, and we'll see you next month with the next edition of SK Dharmalingam. Thank you so much, and signing out. Thank you so much, Doc.
Okay, thank you, everyone. See you around soon. Okay.